right, well, welcome everyone to our second Public Health Grand Rounds. This month we're tackling behavioral health integration, and we have two speakers for you. Judy Holman from the State Health Department and Jeff Thomas from Frontier Behavioral Health. And what we'll be talking about today is getting a sense of the upcoming changes. Decades and centuries ago, we decided to separate the mind from the body, from the mouth in terms of how we provide care. And slowly, we're trying to put those pieces back together, but it's not without complications. These one-stop shops are still a ways off, but we're figuring out ways through policy and laws and cooperation to get people working together to hopefully provide better, more integrated care, bringing those pieces of our body back together. The goal of our Public Health Grand Rounds is to really bring some of these larger issues to all of the disciplines here on the Spokane campus and hopefully enrich our understanding of the populations affected by these issues and our place in these issues, hopefully engaging a sense of compassion and empathy for those who may be struggling disproportionately just due to system and institutional realities. So without further ado, we will hand it over to Judy Holman.
Well, hi, I'm Judy Holman, and I've been asked by Anna to do some behavioral health integration presentation, and just a small piece of what I do. I work with the Department of Health. Previous to that, I worked for the DSHS in the Behavioral Health Administration, and my division was the Division Behavioral Health and Recovery. And my role with the state then and now is I have a team of 10 that go out to agencies that provide mental health and chemical dependency and problem gambling services. And I don't like the word audit, but that's what people recognize. We review them for compliance with Washington state laws, Washington Administrative Code. It's called the WAC, and we'll talk about that in a minute. So I have been doing this since 2011. I went to work for the state in 2011, so I've been able to see a little bit of growth towards integration, and so that's kind of where I'm at is kind of filling you guys in on a little bit of the history up into today. So people sometimes ask, what is behavioral health integration? And it's just that I have a really hard time standing up here and reading PowerPoint, so I'm going to expect that you guys are in school that you can read. So behavioral health integration is just as it says, it's integrating substance use, mental health, and primary health care into one. Why are we interested in doing that? For us, in my position, it's to help the residents of the state of Washington effectively get treatment in one-stop shop. That's what my point is. And experiencing better health care and lower costs. If you don't have to run all over town with mental health here, substance use here, and your primary health care doctor here, you're going to save some money and you're probably going to get better services. So again, why? For a holistic approach to healthcare. And when we say healthcare, that's what we mean, total health. It's not just going to your doctor and getting medicine or a checkup. It's total health care. Behavioral health care is the whole body. It's everything. What we're asking agencies to do in the state at the last sentence of this is to integrate their services. A lot of services in the state of Washington have been more chemical dependency. The real term for chemical dependency is substance use disorder nowadays. I'm older, and so I'm still chemical dependency driven. We're small shops that just did a little bit of chemical dependency and that's it. What we're looking at is a lot of agencies across the state are now incorporating If they're chemical dependency, they're bringing in mental health. They're bringing in a mental health person to provide that service. If they're a mental health service, they're bringing in chemical dependency. So they're integrating the services into one. We believe that integration will improve in prevention, and it will make as I said, the whole person get services more efficiently. One of the other things that you'll notice up here is it talks about commitment to psychiatric hospitals. We again believe that if a person gets treated at one shop, one agency, if you went there for, let's say, chemical dependency services, and they detect that there might be a mental illness, in the past, you'd be sent to another agency for your mental health services. For integration, you can capture that in one spot and detect what might be going on, mental health, chemical dependency, and maybe give the right treatment to avoid somebody going to a psychiatric hospital. So a little bit of the history. In the year 2008, previous to the year 2008, chemical dependency was separated in revenue and services in one pod, and mental health in another. It was, at that time, it was called DASA, Division of Alcohol and Substance Abuse, and the mental health team was Mental Health Division. In 2008, they merged, the state did, and that was before I was around. They merged the two into one. But really what they did is they merged people into one, us into one, and just because you put a cube next to somebody else doesn't mean it's integration. And that's what was kind of being seen is, all right, you're still chemical dependency and I'm still mental health, but we're still separate. So that was part of when we started looking at real integration. That was part of what was taken into the discussion is that that's not integration. So a bunch of people got together before 2013, mandated by legislation and Governor, I think Inslee. I couldn't remember if it was Gregoire or not. And they were mandated to come up with a single set or integrated WAC rules, which put chemical dependency and substance use into one bucket. Well, we did. But it was still not very good because you still had separations. Then in 2014, the Senate passed a bill that we needed to really get serious about integrating. So now we get a little bit more of a push. House Bill 1388 is our final integration bill that went in 2016. Promoted by Governor Inslee and teams to actually have a bill of integration. It didn't pass the first time. It didn't get through the House and the Senate the first time. And so we didn't integrate at that time. So that went to rest for the 6 months while the Senate and House were gone out of Olympia. They came back and revisited that bill. And consequently, the bill passed. And July 1st, of this year, of 2018, is when we actually did integration. And we actually, well, that's next. We'll talk about another thing in a second. I'm skipping around. So again, we have our goals. Safety is important to the state of Washington, safety for our residents, safety in treatment, safety for our providers. It's also important that we don't place, we being my team of reviewers, it's also important that we don't put a burden on our providers. So we don't want them to have 16 different reviews by different agencies. Used to be they had a substance use review and a mental health review. Now they have one review, and it's one team of folks that go in. So that's part of the burden taken away from the provider. So there's rules and laws that we have to follow in the state of Washington. And one of the things that when I put this PowerPoint together, one of the things I remembered when I was I have a MSW, when I was in my program, is that the WACs and RCWs were never spoke about. So when I got out of school, I had no idea until I went to work for an agency what that ever even meant. An RCW is a revised code of Washington. That is a statute, that is a law. And that's what our government does. They write the laws. The law for community mental health is RCW 71.24. If you put that in your computer, you're going to find out that it's got all kinds of things that are associated with it. For mental health for minors is 71.34. The law that we use to detain people for mental illness into like ENTs and hospitals is 71.05. That legally commits somebody to treatment. And then for alcoholism and addiction and drug addiction, it's 7096A. That's a law that we can legally commit somebody to treatment in the state of Washington. And not all states can do that, by the way. Ours is, I don't know if it's unique, but it's one of the few. And then for drug addiction, it's 74.50. Those are important to you if you are planning on going out after school and actually working in public health, to know what the rules are and the laws are. I didn't, and so I was at a loss when I started as a counselor in 1991. WACs, as you see up there, a WAC is Washington Administration Code. So to take that just a step further, an RCW is the start of the rule. The WAC is written from the RCW. So a team of folks, committees get together and write rules from the RCW. That's our WAC. For the preparation of integration, we compiled what we call the single set of rules that went into effect in the state of Washington April 1st of this year. It was called the single set of rules. We were mandated again by Governor Inslee to do that. One set of rules. July 1st, 2018 is when we integrated. My department went from DSHS, we went with the Department of Health. And some of the other folks within our division went to the Healthcare Authority. So the folks, like my folks, that are actually out in the field working with the agencies to make sure that they're following our rules, are with the Department of Health. And then the other people, prevention contractors, the bulk of our opiate people are with the Healthcare Authority. So we got split up. So in answer to that, then we had to take that single set of rules and make them Department of Health rules. Now, the agencies are all awfully confused by this time. They're like, what are we supposed to do? Who do we follow? What do we do? And that's very unfortunate. But that is, in fact, what is now in effect is a Department of Health rules that licenses agencies. CFR 42 Part 2, that's something to really be aware of, and you can also look that up. That is the confidentiality rule for substance use disorder. It is, people that have substance use disorders are highly protected by the federal government, their confidentiality. So if you have a person in treatment, you can't talk to another provider without a release of information. Huge rule. That's a federal rule. Federal rule is over everything else, and so that's a real good rule to pay attention to. That's it. So Jeff is going to talk to you about more community stuff.
Well, a couple of things. First of all, so here you sit on a sunny 70-degree Friday afternoon in September, which makes you either very dedicated or you need to get a life. I'm not sure which. I'm not going to tell you too much about myself, but I'll tell you something about Judy. How's that? Yeah, stay awake. Actually, Judy and I spent a lot of time together over the years. I, as a provider, she is heading up licensing teams, so she's coming and headed up teams reviewing my agencies. And every single time Judy and I have spent time together, it's culminated in her handing me a sheet with scores on it. So Judy, is that going to be the case today too? No scores today. But that process, it is one that's very important for the integrity of services and providers. And yes, our staff at times call it an audit. But that's not precisely what it is. And it's a way for organizations to be reviewed against all of the standards in the labyrinth of all the things you saw up before, many, many requirements and codes and things you wouldn't necessarily know intuitively, some of which make good sense clinically, some of which may not. You have to figure out a way to make it work. So oftentimes, in the best of circumstances, the way it works is the review team and the review lead fulfills their responsibility to make sure that you are cutting muster and doing things the way that you need to, but also providing consultation to you and helping you to get better. And so I just want to say, I don't know if I'll have the mic in front of you again anytime soon, but thank you, Judy, for making us better over the years. It's really, you've done that for many, many organizations. So I'm going to start by just talking a little bit about, from a provider's perspective, why are we doing all this? And it's not a, it's a fairly commonly known stat. About 20% of individuals nationwide at any given year experience a diagnosable mental illness. And that holds true for both adults and for youth. Good news is about 40% have received treatment within the preceding year. And you don't have to be good at math to know that that means 60% did not. So if you have 5 people with a mental illness, 2 of them received treatment in the last year, 3 went untreated. Very challenging. About 1 in 25 adults experiences a serious mental illness. That's defined as schizophrenia, bipolar disorder, major depression, and related disorders. So ones that have a very significant impact on people's functioning. Among those individuals, about 2/3 have 1 or more co-occurring chronic physical health conditions. And that's due to a variety of reasons. It's a combination of impact and side effects of medications, lifestyle. Very difficult to make it a priority, be at the gym at 7 every morning and eat 8 helpings of vegetables if you're dealing with an untreated mental illness. Smoking is another significant, very, very high preponderance of smoking among individuals with serious mental illness. So not only are individuals with serious mental illness more likely than the rest of the society in general to have a chronic mental illness, they're less likely to receive treatment. So one recent study showed that individuals who have schizophrenia and type 2 diabetes, just about half of them are receiving no treatment whatsoever for their diabetes. And you can guess what would happen if people are untreated for diabetes. Individuals with schizophrenia and hypertension, nearly 2/3 are receiving no treatment for their hypertension. So for all the attention we see nationally on treatment for diabetes and hypertension, look at how vulnerable the population is, those individuals living with serious mental illness. So not surprisingly, they tend to have much higher costs. These costs 3 to 4 times as high as the general population, not related to their physical or their behavioral health care services, but the physical health care conditions. Also have a mortality rate that's significantly shorter than the rest of the population. And it's not just individuals with serious mental illness who are at much higher likelihood for physical health care chronic conditions. Many of you have heard the term ACEs, adverse childhood experiences. Many, many studies over the last 15, 20 years demonstrating that the more adverse childhood experiences somebody's experienced, the greater they are at risk for a multitude of physical health care and behavioral health care disorders. In organizations like ours, statistically 90% of those we see have experienced significant trauma in their lives. Many of them 2 or 3 or 4 or 5 adverse childhood experiences. That has an additive effect and makes them much more vulnerable, again, not only for behavioral health care challenges, but physical health care. When you look at the cost side of things, we're talking about Medicaid funding for the most part under public mental health. So same prevalence in terms of mental illness, but 50% of the cost, you look at the slides I had up previously, when you look at the cost around the behavioral health care side and physical health care side, 20% of the population of the Medicaid covered lives accounting for 50% of the cost. So now we have a health imperative, a human caring imperative, and a economic imperative to be looking at how do we treat the whole person? How do we bring this together? So as Judy pointed out, there's by history what we call a siloing effect. We have payment for substance use disorder treatment, payment for mental health, payment for physical health, all under different structures, different licensing, different requirements, different contracts, different providers in many instances. Leads to very much not whole person integrated care. So there's something very simple and elegant about moving it all into one silo, right? It really can facilitate positive things. However, from a provider standpoint, it's not without some challenges. So here's how it's looked by history for we as providers. For the bulk of what our organization does, it's not, we have 30 or 40 or 50 contracts at any given time, a lot of real small ones, but the majority of what we do is under a contract with one single payer, Spokane County Regional Behavioral Health Organization. Beginning January 1st, 2019, well, we're going to have 3 different Medicaid managed care organizations who we are contracted with. You see their names up here. And actually, because they're the ones who are awarded the contracts through a competitive bid process for our region of the state. And we're also going to have a contract with a 4th of the 5 MCOs because Coordinated Care received a contract for a carve-out of the physical and behavioral health care services for the foster care population. So we have a 4th boss. And then we as a crisis service provider are going to be contracted with something called the Spokane County Regional Behavioral Health Administrative Service Organization. So now we've got a 5th boss. So while things are getting less complicated on some fronts, if you talk to my finance and IS and data and compliance staff, life is just about to get much more complicated. So I'm just going to share with you one example of how care can be better integrated, and it's really what I would consider sort of the low-hanging fruit. It's a terrific example of how not coordinated things have been in the past and some opportunities in front of us. And that has to do with, remember the statistic I shared of individuals who go untreated? 6 out of 10 individuals with a mental illness do not receive treatment within the preceding year. Many of those individuals are showing up, not all, but many of them, with their physical health care providers. In fact, a side note, 75% of individuals who complete suicide have seen a physical health care provider within the preceding 90 days. So when we think of these individuals, many of them coming into contact with their physical health care providers, let's look at how the process has worked, or has at least supposedly worked. So somebody comes into their physical health care provider and they identify maybe there's a behavioral health care issue. And they know that there's some resources out there, so they say, you know what, Judy, why don't you head down the block, go to Frontier Behavioral Health, and I think it's a great agency and they can help meet your needs. So she says, and not only that, but here's a number, here's a card, take it with you, and let me know how that goes. So the patient calls for an appointment, says, Frontier, I'd like to get in. They get an appointment with a provider. They make it to the appointment. They're able to tell us as the behavioral health care provider who it was that referred them so that we can loop back and share with the primary care provider what came of the matter. That looks actually pretty nice and simple and elegant. But let's look at some of the potential failure points here. Failure point 1, the PCP may not have received any training such that they have any way of being able to accurately screen, not to diagnose, but to screen for the possibility of a mental illness or substance use disorder. They may not know the resources that are out there or the referral process. Organizations may have many different referral processes, and this poor PCP may not be versed in any of them. They're busy practicing medicine, not versing themselves on a bunch of resource guides out in the community, figuring out where they can send people and what the process is and what the paperwork is. So who do we have being the point of continuity that's responsible for getting the person into care? It's the patient. So, do they call for an appointment? Do they take that card and make a phone call? Maybe. If they make the call, do they get in? Maybe. Maybe there's an appointment, maybe there's not. Sorry, we're all full. Call somebody else. Do they attend if they get the appointment? Maybe. 25 to 30% no-show rate, by the way, and that's people that get to that point. We don't even know how many are in the previous maybes. Are they able to tell us who referred them? Sometimes. Sometimes not. Oftentimes not, surprisingly. Yeah, it was that nice lady at Rockwood, and forget her name. Well, it was like, 30 of them. Which one was it? Hard to get back to the nice lady. Call up and say, which one's the nice one? Right? me, they all are. So what happens? The loop doesn't get closed. That's a lot of failure points, right? A whole lot for individuals who most likely are in need of and would benefit from services and are really struggling with behavioral health issues, mental health issues. They're going to have a serious impact on their health and on costs if it goes untreated. So here's the opportunity. And this will sound so simple. Why haven't we done this sooner? Well, for a variety of reasons, but sometimes you just really need to bring attention to bear on an issue to look for the opportunities. So, train primary care providers in screening. Give them a little bit sharper lens to look through to identify individuals who may be struggling with a behavioral health issue. Establish referral processes that are similar to and give the same accord to the importance of behavioral health services as we do to other specialties. So if you get a referral from your primary care provider to a cardiologist or to a pulmonologist or to a physical therapist by history, guess what? Probably they're going to get notified that a referral was made. I happened to go for my annual physical the other month, and they wanted me to go to inland imaging and get some sort of a scan. I got a call the next day from inland imaging. Hey, Jeff, so glad you referred. When can we make it convenient for you to come on in? I didn't have to do anything. I said, pick up the phone in response to them calling me to engage me. But yet, by history, we've taken the individuals who, by virtue of the symptomatology of their illness, are arguably the least likely in the least good position to follow through and made them the most responsible for following through. Well, that's ironic. So what can we do? We know somebody's referred, we can reach out. Just like happened at inland imaging for me. I can call Judy and say, hey, Judy, we heard you were referred. How can we make it work for you? Let's get you in. There's no such thing as no appointment. In our organization, and increasingly in some others, open access. Judy, if you'd like an appointment, that's terrific. If you want to come on in Monday through Friday between 8 and 2:30, you might have to wait a while, but come on in. Judy doesn't show. Well, we know that Judy's referred, so we can reach out to her and say, sorry that didn't work out for you, but we'd sure still love to have you come in. Was there a challenge with the time? Maybe a transportation barrier, some other reason that, what can we help you with that will, we want you to come in, we welcome you. It's a priority to us that you come in and get the care you need. How can we assist you with that? And we know who referred because we were told at the outset. So what can we do? We can loop back and provide information to the referring provider. By history, and we've talked to provider after provider, the only way they would know by history if somebody ever did anything with that business card and got the care they needed, if they show up back at another appointment at some point with the PCP and are an accurate reporter about what happened, about where they showed up, much less any knowledge about diagnosis, medications, interventions, any of that. A little bit more integrated way of going about it, right? And this is stuff that's real doable, and we're already in process with a number of major physical health care providers putting these processes into place. So in terms of possible future opportunities, and this is going to be a flyover some possibilities, but the first is the one I was talking about. So increasing what we call mental health penetration rates. We know there's so many individuals who go untreated. If we can move the dial on that, get more people the care they need so they aren't entering into behavioral health care services by virtue of psychiatric hospitalization, emergency departments, or unfortunately heading into the largest mental health institutions in our nation, the jails and the prisons. exchanging information between providers. Well, right now, talk about the bar being set low. Right now, we don't even know if we're sharing patients. And that's point one of information, much less what somebody's physical health care diagnosis is if we're a behavioral health provider, or what medications they might be on. So we're really in a dearth of information that there's opportunity that we can provide better care if we know what's going on the physical health care side and vice versa. Coordination between providers. A lot of this is going to occur not necessarily just through say the physician, the psychiatrist, and the pulmonologist or the primary care doc. A lot of that's going to be in the form of, we have several different positions at our organizations now through different pilots. Call it care connector in one case. It's we have an oral health care navigator position. There's a hub and spoke opioid treatment program that's starting. We have a spoke navigator. These are all uncredentialed positions, but highly skilled engagers who are essentially there waking up each day saying, how am I going to help to be, they're kind of, I call them the glue people, to connect folks and help them navigate their way through systems that it can be complex, the paperwork that can be daunting, all those barriers that can get in the way of people getting from point A to point B. Information from payers. So part of the benefit of the knocking down those silos is we'll be able to have information. Right now, we don't know unless the patient tells us if they've been hospitalized for a medical reason in the emergency department for a medical illness. We don't know what's going on that side. Being able to have information from the Medicaid managed care organizations, because they're paying for physical health and behavioral health, there's an opportunity for information to be pulled together. Patient registries is a real short word for being able to have in one spot information that transcends substance use, behavioral, mental health, physical health care in terms of diagnoses, in terms of claims-based information, services people are receiving, lab results, services they're not receiving, gaps in care, the sorts of things that can help inform a whole person approach, which can assist us in our organization, as an example, in playing a role in helping individuals manage their chronic health conditions. Remember the statistic that I shared, around 2/3 of individuals who have a serious mental illness also have a co-occurring chronic health condition. And depending on which study you're looking at, oftentimes about half of those individuals are not receiving care for their chronic health condition. Well, by our doing some arithmetic on the numbers of clients we serve, our estimate is that at any given time we have probably at least a couple thousand, probably 2,500 individuals with an untreated chronic health condition. And they're showing up in our office. We're seeing them for medication management, for their psychiatric conditions. We're providing case management. We're providing counseling and therapy. And here they are dying of diabetes and hypertension, and we don't know it. Well, if we have the kind of information that you see above, and we can take action on that, not to provide that care, but to then assist through care connectors, care navigators, the glue people, help connect them and get them to appointments. We couldn't help but notice that you haven't had your labs in 2 years, but you're diagnosed with diabetes. How can we help you, get an appointment? Can we assist you? Can we attend with you? Can we transport you? What would be the barrier? We'd really like to see you get well. Transitions in and out of outpatient and inpatient care is certainly an opportunity. One of the things, though, that we're very attentive to in behavioral health care, by nature, we have to be an episodic care provider. So if you have a primary care provider, you are what you would call empaneled with them. You're on their panel, and probably you're going to be on their panel until you move or leave or fire them or they fire you. Well, it can't work exactly the same way in behavioral health, because we've got 530 people coming into our outpatient programs every month, 530 a month. If we don't have 530 leaving every month, you can see we're going to have a problem at some point. So some people stay with us for 3 months or 6 months or a year or 2 years or 3 or 4 years, but we have to have a back door. And by history, one of the ways this has worked is individuals leave our care. Sometimes they're just sort of doing better enough. And we say, well, if they aren't at high risk, we don't go knock on their door. If they are at high risk, we do go knock on their door. But otherwise, we send a letter and say, you're welcome to come back at any point, but not a lot of benefit in us continuing to schedule appointments that you're not showing up for. So here's our number, and call if you'd like to get back into services. And then they'll show up at Chaz or somewhere 3 months later with 6 different pill bottles that are all empty saying, I need all these filled like now. And these are a bunch of psychiatric medications, and the poor Chaz provider saying, oh my goodness, what am I going to do with this? Well, there's opportunities for us to work with our primary care providers through care connector types of work, sharing of information, to where somebody leaves our care, we could say, hey, Judy here is no longer enrolled with us. We know she's with you, Chaz. How can we help her get a timely follow-up appointment? How can we consult with you on medications that she may be on that you might have questions about, that you might be asked to prescribe and that she's probably in need of because they've been helpful to her? So figuring out ways to have some fluidity, not only in terms of concurrent treatment, but consecutive treatment between physical and behavioral health care providers. And then the final piece is a really big topic, which very difficult to even wade into at all, but population health approach in part talks about looking at individuals by grouping. So, and an example I will use is individuals who have schizophrenia and diabetes. We're in discussions with our physical healthcare partners saying, how do we identify, we'll be able to know jointly who those individuals are and that we're jointly treating them. How do we stratify risk in terms of those we need to take certain levels of intervention with and be more aggressive in our treatment? What are the clinical pathways we're going to pursue for those individuals, such that we're not just serving those people who show up and providing what becomes kind of obvious to us that they need at that time. But we have a lot of individuals that are falling through the cracks because they end care and nobody's really attending to kind of given the risks that they're at on the physical and behavioral health care side. If something isn't done, if somebody doesn't reach out to them, and if there isn't some sort of a proactive intervention to engage them, bad stuff's going to happen for them down the road. So taking a more proactive approach. Final thing I'll say is, as we look at all of this and the opportunities and the complexities, I believe it can help to accomplish something you may have heard called the triple aim, right? Better care for patients, better outcomes, and reduce costs, or at least costs that are increasing at a lesser rate. But there is a fourth component that's been talked about in the last few years, thankfully, and we as providers have been talking about it all along. They're not talking about the quadrupling. We've got to think about the providers, the clinicians, the people that are providing the care. If it's not working for them, we have a bunch of wonks or administrators figuring out, well, here's how it ought to look, here's how it ought to be organized, and it looks good on paper, and it's not working for the providers, it will not work. So they have to be included in the process. Their time has to be honored. And if we give a physical health care provider who has 15 minutes, generally speaking, for appointment, a task that takes 2 or 3 extra minutes, well, by the time the patient's a minute or 2 late, something else, there's 30 seconds of small talk, and then they're supposed to open up a portal and access behavioral health information that takes them 3 more minutes. They won't do it. So we get down to the gnat's eyebrow to where we're even looking at, okay, how can we have the icon to where it's 1 click away and not 2 clicks away, so they can open a portal that tells them just the 3 bullet points of information: last appointment, current medication, most recent medication change, next appointment. Period. I mean, they might be interested in opening up a chart and reading somebody's life history, but they don't have the time. So we have to be very mindful of what's going to work for the providers. Otherwise, good concepts aren't going to translate into good care. So I guess with that, you're going to make us open it up to questions. I mean, we would love to invite questions. No, we're wide open to questions. And I think one microphone is going to be traveling. Is that what you said?
So there are lots of providers for counseling and such in the community. Are they going to be continuing, or all of them are going to be under the umbrella of Frontier Behavioral Health?
No. Yeah, I'm just representing one provider. Yeah, so there are all, to my knowledge, there's not a single provider that's contracted under the BHO that will not be contracted under the Medicaid managed care organizations, thankfully, because we need all of them.
Okay. And that was the other question is, you said, there won't be any waiting list for people to get into the counseling in a timely manner. Do we have the workforce infrastructure to address the needs of number of people who are going to be asking for services?
That is a really good question, and the answer is no, we do not. We're at a pretty significant workforce shortage juncture. And there's a lot of factors contributing to that. That's integrated care is not something that's a precipitant for that. When we look at things like mental health parity laws in recent years, which expands access to mental health services, when we look at Medicaid expansion, where there's 600,000 more people on Medicaid in our state. So in our organization, we had a 50% increase in individuals coming into our care each month based on Medicaid expansion and our open access model. 50% if you're looking at current year versus 2012. Well, there are not 50% more psychiatrists, 50% more social workers, 50% more CDPs or anything. So that is at the crux of the matter. It's very, very challenging in terms of workforce. One part of the solution, although not all, is to be creating additional roles and functions that can assist in providing whole person integrated care without tapping the time of the clinical providers. These other non-credentialed positions, but they need to be highly skilled in areas like engagement, so the care connectors, care navigators. We feel like that, it's by history, some of our clinicians have been asked to do a high amount of their time kind of fulfilling those functions. So we're having to be creative in terms of how we go about accomplishing our work, but absolutely that's a worry every day of ours.
And the last question is around the communication as far as the healthcare provider, PCP, and with the behavioral health provider. How timely is the communication, and so in excess under the federal law, the confidentiality issues and such, how is that addressed right at the beginning so that there is a communication between the healthcare provider, physical healthcare provider, and behavioral health provider?
Yeah, and there's a lot of questions within that question, but short answer is physical healthcare providers are not bound by 42 CFR and HIPAA is so wide you can drive a truck through it pretty much. They can tell us, hey, I'm treating this person and I'm referring them to you. That's great. The challenge has been they haven't had a mechanism that's structured that makes it easy for them to notify us that they're referring somebody our way. So are they going to fax something or do something really clunky and time consuming? So we're actually working with some physical healthcare providers to have something that's, right, if you're a primary care provider and you can literally click on their medical record and a drop-down menu that says, a cardiologist or a pulmonologist or a physical therapist, next one would be, a behavioral healthcare provider. They click, off it goes. They spent, 2 seconds and now they know that we know that the person has been referred, so we can start connecting. So, I think when you talk about what it's been like, it's different than what it's going to be like once we facilitate the process more robustly.
Hi, yeah, I wanted to ask about policy. You're talking about open lines of communication. I was wondering if you have people sign a two-way release of information when they come in for intake so that the clinician can talk to the PCP.
One of the things that we do as a state agency is when we do a review of an agency, that's what we look at as releases of information to assure that there's a release of information for every person that a clinician at the agency may talk to. It's a requirement of the Washington state laws to have releases of information before you can talk to somebody else. You can refer a client in to an agency, but the agency to talk outside has to have a release.
Right. I was just wondering if that's policy for the behavioral health to, during intake, to make sure that that has already been signed and cleared so that
it better be.
Last time I looked, we got a 92% on that. No. Yes, absolutely. We do that on the front end to make sure. Yeah, because absent that, it makes it very, very challenging. So good question.
I have a question from one of our online attendees. They are asking about the Medicaid transformation and all the waiver activities, the collaboratives, accountable communities of health. How do you see this impacting, and how quick will we see the impact of those activities on behavioral health integration?
Yeah, that's a great question. That's a whole other big topic, and it's a lot of effort and a lot of attention going into it, and for good reason. And it's coincident with our move to integrated managed care. So I happen to be on the board of directors for Better Health Together, our region's accountable community of health. I'm co-chair of the waiver finance committee for the Better Health Together, accountable committee of health. And people ask me all the time, well, so they expect that I know all the answers. I'm like, man, there's a lot of shifting sands. And there aren't clear answers, but I will tell you that there's a lot of opportunity for what's going on in terms of the Better Health Together, again, which is our accountable community of health, using those Medicaid waiver dollars to give sort of a, for lack of a better term, a power assist to some of the efforts that providers are going through to figure out their way through ways to better integrate care and make some of the changes. So the fact that they're coinciding is, on the one hand, one extra thing on top of another makes it challenging. On the other hand, I think there's some ways in which over the next year or two, there'll be opportunities to facilitate that process. With three of the largest behavioral health care or physical health care providers in our region for Medicaid population, we and they jointly listed each other in our partnering provider plans that we had to submit as a part of that process. And we have some pretty involved, detailed plans as to how we're going to integrate, and we're hoping to receive some dollars to support that effort. The question.
So my question is, will all of the hospitals and the providers be under like one software so that they can streamline and send that information through? Is that the hope, that there will be one software that everyone will be using? Or will it be like Rockwood is using their own through their network and vice versa?
Yes. You are so silly. There's no chance at all that it would be under one EMR. Multi-care, you may be aware, just went onto Epic, which is what Providence is on. No physical health or behavioral health care providers are on Epic. It did not even have a behavioral health component that would help us to meet all the reporting requirements we had until, I'm told, their most recent version might. But there's but I'll say this, we need not and should not and cannot wait for one EMR to be moving forward with this. And even if one electronic medical record existed, that would not solve the problem. That's not the road to Mecca. It's a lot of these other things, and we're finding ways to do pretty simple, elegant workarounds through secured portals and access and sharing of the right information with physical healthcare providers. Yes, it'd be handy if we're all on one EMR, but that's not requisite, and which is good because it ain't going to happen anytime quick.
Is there any possibility where behavioral health and physical health would be under the same roof rather than being at different locations?
Yes, and that is occurring in some instances. Some of the physical health care providers are providing behavioral health services in their clinics, and some behavioral health care providers are providing through partnerships, perhaps, or on their own, some physical health care. We have partnerships with both of the local federally qualified health clinics to where they provide some services on site on our main campus. But let's say that magically, so yes, that does occur and can occur, and it's helpful, but a couple of caveats to that. Let's say that magically we could hire 50 physicians and employ them all at Frontier to see all of our clients. That might sound good because it's one-stop shopping, but here's what happens. Remember I said we're kind of have some throughput. We have to have kind of care that is limited because we have 530 people coming in, 530 people leaving each month, right? So when we're providing care that isn't forevermore, but yet oftentimes the best continuity for care on the physical healthcare side is for people to be empaneled with a provider over years, then for us, the way we utilize on-site co-located services isn't to say, hey, if you're enrolled with behavioral health with us, we want you to come and get your physical health care on site. What we do is say, if you are either not connected with a physical health care provider, a primary care provider, or you're connected with one on paper, which by the way happens a lot, you're enrolled with Chaz or Unify, but they haven't seen you in like 4 years. Okay, then we say, how about you come on in and get re-engaged in, or newly engaged if you're not enrolled with anybody on the primary health care side at this clinic, and then get established as a patient, get some continuity, and then transition to a primary provider in their neighborhood. So they can have that continuity when they leave our care versus, getting them paneled with somebody who's on our location, and then they have to start all over, not only behavioral health care side, but on the physical health care side when they leave us. So yes, I think there's an important role for co-location, but it's also not a one-size-fits-all. I've also talked to some providers at organizations that I will not name on the physical healthcare side who said, yeah, our administration thinks we have integrated care. I got this social worker over here, this psychologist there, and a counselor there. I see them in the hall. They seem like nice people. That's about it. That's not integrated care. It's not just plunking people next to each other.
No, I was looking in terms of the timely access to the behavioral health. Person doesn't have to wait and go to the next person. I mean,
I think a terrific model that's going on, and Chaz does this, I think Unify's doing some of it. Providence is doing more of it. Multicare is looking at doing it. I don't think I'm speaking out of turn. They've spoken publicly. Is creating these behavioral health specialist type positions to individuals who are not, who might reside. You might have one of them in a clinic with 5 or 6 primary care providers, and their job isn't to build a panel and be seeing people for long-term therapy. It's to provide pretty on-the-spot intervention, maybe brief intervention, see people 2 or 3 or 4 times. If they're needing longer-term care, then refer them to our organization or an organization like ours. So I think there's a real important role for that sort of a model, but it's a bit different than them just sort of saying they're going to do the whole thing.
thank you.
Pardon me? Yeah. Yeah, it is. Yeah.
I've got one more question from our webinar attendees. You mentioned regardless of how well services are integrated, it's not going to give us increased capacity because there may not be enough providers. So what do you see are the most encouraging signs of encouraging an upshoot in the workforce numbers for mental health providers?
Yeah, I don't know if that was exactly what the integration is not going to make the problem worse. It's not going to in itself make it better. I think there are opportunities for us to be more creative in terms of the ways we utilize positions and attain greater efficiencies. An example is if we have folks who are not engaged in care and they're, we have caseloads of individuals who are, somebody has a caseload of 70, but 30 of them aren't being seen, but you got to manage all the paperwork and keep doing the authorizations and the treatment plans. That's not very efficient. So figuring out ways to engage those individuals in care, get them the care they need so they can be healthy and moving on to the next stage. But there is a lot that we're trying to look at in terms of workforce recruitment and development. The biggest thing that I see, and some folks get tired of me saying about it, but I've talked to folks at individuals at Greater Spokane Incorporated, through the BHT Learning Collaborative, through our various payers and partners. We have a limited pool that we tend to hire from within Spokane. So what happens is providers move from one provider to another, and what we need to do is bring more people to Spokane. That's what we need to do and I'm real interested in us, and we have a lot to sell here in Spokane as a community, as a healthcare provider community, as a behavioral health care provider community. And we need to do some national recruitment efforts saying, come to Spokane, it's a great place to work, it's a great place to live, it's a great place to practice medicine and healthcare and behavioral health care. Let's not just cannibalize each other's staff constantly. Let's really look at how we get more people here. And that's going to be a big part of the answer.
I wanted to just come back to you for a second. When you asked about Frontier being the only shop in town, which no, it's not, and Jeff answered that quite well. We license in the state of Washington 944 agencies throughout the whole state of Washington. The sad part of that is about a quarter of those are in Eastern Washington. And so what we really have to also focus on is how we can develop services on this side of the state. I'm actually from Clarkston, which is 100 miles south of here, and I moved to the west side of the state in '96 and moved back No, I was never going to move back to Clarkston. but don't ever say never. So I moved back to Eastern Washington in 2015 and still work for the state. I'm an outlier, so I have to go to Olympia a couple times a month. But nevertheless, my point is, I know what the lack of services are in Eastern Washington, and I have made a point of making sure that everybody that I talk to on the west side of the state hears me. I had to access service in a life before my professional life, and it's not easy on this side of the state. It's not easy to access services. It's not easy to have services, and it's not easy to employ people on this side of the state. So Jeff's point is well taken. Our workforce development in the state of Washington is in trouble. We don't have people going into the field. One of the reasons is because it doesn't pay that much, and we know that. So there's a lot of work to be done, not only for the workforce, but the workforce are the ones that work with our clients, and our clients are the ones that get the value. So that's my little soapbox. Thanks for listening.
Any other, maybe time for one more question? All right, well, thank you so much. All right, so before everyone takes off, a couple of announcements. If you'd like access to the recording and the PowerPoints and other handouts and resources and links, you need to make sure you sign up with us. There is a tablet just outside this door. If you give us your name and email, we'll make sure you're on the link and you will get connected to all of those things just after. Because we got a quality recording this time around. Yay for us. You'll also receive an evaluation form, and we're hoping to continue this series on through next year. So we're looking for topics. And so your evaluation form you'll get in your email box will be your way of letting us know what kind of things would you like us to tackle next year. And hopefully you all picked up a little handout that gives you an outline of what we're going to cover this year. And so make sure you take it only takes a couple of minutes. Let us know what you thought and what you'd like us to tackle in upcoming sessions. And next month, we have a bit of a change up, but not too far off. We're tackling suicide and suicide prevention. And so our guest speakers will be Sabrina Votava, who's the Executive Director for Fail Safe for Life, and Stacy Che with our EWU School of Social Work, who does a lot of work around suicide and suicide prevention. Same location in this room, 4 o'clock on October 26th. We'll also have an online streaming link for those of you who can't join us in person. But we look forward to hopefully seeing you in October. Thank you for coming, and we appreciate your time on this beautiful sunny afternoon that you spent with us. Thank you very much.